Hello everyone, welcome back to our channel Dr. Ashmita NEET PG. I'm Dr. Ashmita. In this video, we'll discuss about the previous year questions of NEET PG 2025. So let's begin by reading out this first question. Which of the following types of cell death involves activation of caspase enzymes? The options here are necrosis and apoptosis, option 2 apoptosis and pyroptosis, option 3 apoptosis and necroptosis, option 4 apoptosis only. So before solving, let's discuss each one of the terminology in detail. So firstly, this image shows you the apoptosis. Apoptosis is an controlled cell programmed cell death where there is involvement of caspases. So this apoptosis has this extrinsic pathway and an intrinsic mitochondrial pathway. This extrinsic and intrinsic pathway involved caspases. See here, there is caspase 8, 9 and 10 in the initiation phase. In the execution phase, there is 3, 6, 7 caspases, and in the intrinsic pathway, there is caspase 3 involved. So all the caspases are involved in this induced form of cell death, that is apoptosis. The second image, this is the pyroptosis. Pyroptosis is associated with infection. There is infection and inflammation where this bacterial product will activate an inflammasome called NLRP3. This is the inflammasome that got activated, which in turn will activate the procaspase into caspase 1. So the caspase 1 is now activated, which will convert pro-interleukin 1 beta into interleukin 1 beta. So there is release of interleukins in pyroptosis. Because of microbial infection, caspase 1 got activated, which will convert the pro-interleukins into interleukins. This interleukin 1 beta is responsible for fever, that is rise in temperature. Rise in temperature is also called pyro, hence the name pyroptosis, which will result in cell death. So, there is microbial infection which will result in caspase. There is involvement of caspase, also results in the release of interleukins producing fever. This is one form of cell death called pyroptosis. So in both apoptosis, pyroptosis, there are caspase involvement. This image shows necroptosis, which is driven by RIPK1, RIPK3 and MLKL. So there is no caspase here. There is no caspase involved in necroptosis. Necroptosis is also a controlled form of necrosis. It is a controlled necrosis with inflammation. This image shows you necrosis, which is an accidental cell death due to severe injury. Severe injury, it can be stress, trauma, anything. Because of severe cell injury, cell death occurs. It is associated with cell membrane damage. Membrane gets damaged, resulting in leaking of contents, leakage of cell contents, all the enzymes. Hence, it is associated with inflammation. There is inflammation present in necrosis. And there are no caspases involved here. No caspases. So both necroptosis and necrosis, there are no caspase involvement. Only apoptosis, which is a controlled form of cell death with caspase involvement, and there is no inflammation here. Even pyroptosis associated with infection, release of interleukins, there is caspase 1 involvement. Hence, apoptosis and pyroptosis both show involvement of caspases. Hence, the answer for this question, that which type of cell death will involve activation of caspases, will be option 2, apoptosis, pyroptosis. Also, you can remember like this, caspase, it has A and P, apoptosis, pyroptosis. So both apoptosis, pyroptosis will show caspase activity. So this is about the first question. Let's move to the second question. A 68-year-old man presents with bleeding manifestations. The peripheral smear shows presence of the cells shown below. Which of the following is the most common chromosomal abnormality seen in this question? So from the given question, it is an old man, 68-year-old, with bleeding manifestations strongly suggestive of disseminated intravascular coagulation (DIC), and the peripheral smear showing these characteristic cells. These are the large myeloid cells called promyelocytes, filled up with OR rods. These characteristic rod-like structures filling up the cytoplasm of these cells. These rods are called OR rods seen in promyelocytes. So the history of an old person with bleeding manifestation, that is DIC, and here the smear showing this OR rod filled cells, that is the phagote cells. OR rod filled cells are the phagote cells. It is suggestive of acute promyelocytic leukemia. Acute promyelocytic leukemia, which is the M3 stage of AML. M3 stage of AML. The most common chromosomal abnormality in this M3 stage of AML is translocation 15-17. Let's see each of the cells, the stages of differentiation of myeloid lineage to understand. First, it begins with a blast stage, that is the myeloblast, which is largest cell. This is the second largest cell. It has high NC ratio, like the nucleus is big, scant cytoplasm like a rim, and there are prominent nucleoli. Prominent nucleoli are present. These are the nucleoli. Second stage, the myeloblast will develop into a promyelocyte, which is the largest of all cells. This is the largest of all. This promyelocytes, the cytoplasm contains certain granules called primary azerophilic granules. These are the primary azerophilic granules. Also, certain rod-like structures called the OR rods. The OR rods, better appreciated in the image attached to the question. OR rods are predominantly seen in promyelocytes but can also be seen to some extent in the myeloblasts also. But as soon as OR rods are seen, it is like predominantly seen in the promyelocytes. After promyelocytes, the third stage is the myelocytes. Myelocytes, characteristically, they have a D-shaped nucleus, eccentrically placed D-shaped nucleus. Next is the metamyelocyte, which is the fourth stage. Metamyelocyte characterized by this indented nucleus, like a kidney bean shaped. It is a kidney bean shaped nucleus or an indented. It has an indentation, indented nucleus. After the metamyelocyte comes the band forms. The band forms have this U-shaped nucleus. More indentation is very deep than the metamyelo. So this indentation is more than 1/3 of the diameter. This is called a band form. After the band form comes this mature neutrophil, which is characterized by this segmented nucleus. All the segments connecting segmented nucleus. This is the neutrophil. So the promyelocyte will develop into myelocyte. Here, if at all there is a translocation between 15 and 17 chromosomes, here this is the 15th chromosome which contains PML gene. PML means promyelocytic leukemia gene. Promyelocytic leukemia gene present on 15th chromosome. Chromosome 17 has this RAR alpha gene. RAR alpha means retinoic acid receptor alpha gene. Whenever the translocation occurs, this translocated to this will get translocated to this. So this is the 15th chromosome, this is the PML gene, this is the 17th chromosome which contains this RAR alpha gene. Now it has gone translocation. This PML part of it moved here. This RAR alpha which was originally present, it has moved here. So there's a fusion occurring. This PML gene, part of PML gene, part of RAR alpha gene. undergoes fusion on chromosome number 15. This fusion gene is responsible for the acute promyelocytic leukemia, whereas this chromosome 17, this fusion, it remains non-functional. It remains non-functional. Only the translocated 15th chromosome that harbors this PML-RAR alpha fusion gene, it is responsible for this acute promyelocytic leukemia. Hence, here this question with bleeding manifestation smear showing this phagoid cell, that is the promyelocytes. It is highly suggestive of acute promyelocytic leukemia because of translocation 1517. It gives PML RAR alpha fusion gene. Because of this PML RAR alpha fusion, PML RAR alpha or the RARA fusion, because of this fusion, the promyelocyte becoming the myelocyte does not happen. The block occurs here. Block. This will get blocked. This differentiation does not happen. Hence, promyelocytes increase. They get accumulated and increased, and the peripheral smear is filled up with this promyelocytes. So the treatment here is all-trans retinoic acid, ATRA, all-trans retinoic acid, which will remove this block here. So this block will be removed. Whenever this block is removed, again the promyelocytes will start differentiating into myelocytes and they proceed further. So all-trans retinoic acid is the treatment given in acute promyelocytic leukemia. So this is about the second question, old person with DIC and this phagoid cells containing OR rods. This DIC is because of this OR rods. OR rods contain a procoagulant material which is responsible for this DIC. This is about the acute promyelocytic leukemia, which shows translocation 1517, which gives PML RAR alpha fusion gene. Let's see the other options. See translocation 821, which is M2 type of AML. So let's see this table, the FAB classification of the acute myeloid leukemias. We have discussed M3 acute promyelocytic leukemia. It shows hypergranular promyelocytes with many OR rods, that is the phagoid cells. Whereas here the translocation 821, it is this M2 stage, and the inversion 16, AML with inversion 16 is the M4 stage with eosinophilia. So the other option here, the inversion 16, is M4 stage, that is acute myeloid leukemia M4 with eosinophilia. Whereas this translocation 1418 is the follicular lymphoma. Follicular lymphoma. So this is about the second question. Coming to the third question, a lymphoma characterized by presence of centrocytes, centroblasts, along with BCL2 positivity and CD10 expression is most commonly associated with which chromosomal translocation? So the question here says there is presence of centrocytes and centroblasts. So centrocytes are there, centroblasts are there in this lymphoma, along with BCL2 positive and CD10 positivity. So it is associated with which chromosomal translocation? The options given are translocation 2,5, translocation 8,14, translocation 14,18, translocation 11,14. Before solving, let's have a brief idea about the lymph node, the B and T cells. So this image shows the structure of a lymph node. This is the capsule. Beneath the capsule is this cortex. This is the cortical region. This is the medulla. In between is this paracortex. So the cortex contains this spherical structures called follicles. These are the follicles. They contain B cells. The active follicles, they have a germinal center. That means a pale zone in the center of follicle is called a germinal center, which contain B cells. So the normal germinal center B cells, they are positive for CD10. They are positive for CD10 and they are negative for BCL2. BCl2 will be negative. This is the normal phenomenon. And in the paracortex, between the cortex and the medulla, they contain T cells are present. So this is the basic idea of the lymph node. Here they are saying there are centrocytes and centroblasts which are present in the germinal center. These are present cells of the germinal center. And there is BCl2 positive and CD10 positive. So both are positive. So it indicates a lymphoma called follicular lymphoma. That is translocation 1418. It is a follicular lymphoma which has CD10 positive because it arises from the germinal center B cells. Also, it has BCl2 positivity expression which is abnormal. So, because of these two positivity, it is follicular lymphoma which shows this translocation 1418. Why not the other options? Translocation 25 is anaplastic large cell lymphoma. So, which is a T cell lymphoma. T cells means they are present in the paracortex. So, there will be no centroblasts and no centrocytes. Also, because it is not arising from the germinal center B cells, obviously the CD10 will be negative, BCl2 will be negative. Coming to the second option, translocation 814. Translocation 814. Coming to the second option, translocation 814, which is Burkitt lymphoma. Which is a Burkitt lymphoma. Burkitt lymphoma, they arise from the germinal center B cells. So, they are positive for CD10 because they arise from the B cells of the germinal center. But they retain their normal expression, that is BCl2 will be negative. BCl2 will be negative. That is a normal expression retained in Burkitt lymphoma. Therefore, for the given option where both CD10 and BCl2 positivity, this option doesn't fit. Coming to this fourth option, translocation 1114 is a mantle cell lymphoma. It is a mantle cell lymphoma. Mantle means this is the follicle, the center is the germinal center. Mantle is the outer layer. So, it is not arising from the germinal center. Hence, CD10 will be negative. CD10 is negative. Also, BCl2 will be negative. So, since the question says both CD10, BCl2 positivity, the only option that fits in is this follicular lymphoma showing this translocation 14 and 18. So, translocation 14-18 means this 18th chromosome it will harbor BCl2 gene, whereas 14th chromosome will harbor IGH gene. Because of translocation, the BCl2 gene move towards the 14th chromosome. So the final 14th chromosome will have this IGH and BCl2 because of which there is BCl2 over expression leading to follicular lymphoma. So this is about the third question. Moving on to the fourth question. A 30-year-old man presents with a painless testicular mass. On ultrasound shows well circumscribed, homogeneous, non-hemorrhagic testicular tumor. Which of the following is the most likely diagnosis? And the picture is attached here. The option says yolk sac tumor, choriocarcinoma, teratoma, seminoma. From the given question, the clues are it is a painless testicular mass and homogeneous non-hemorrhagic testicular tumor. And the image showing you this typical cells with central nucleus, distinct cell borders, clear cytoplasm. So here also there is a nucleus, cytoplasm clear distinct cell border. So this is like appearing like fried egg appearance of cells. And there are delicate septa. These are the septa. In between these are the delicate septae. They contain lymphocytes. So lymphocytes present in this delicate septae. So the typical fried egg appearance of the cells and septa containing lymphocytes with a painless mass and non-hemorrhagic tumor. That means it points towards seminoma. Why not the other options? Yolk sac tumor, it typically has this, it shows this scalar dual bodies. Scalar dual bodies which has this is a central vessel. Surrounding the central vessel are the layers of tumor cells. Scalar dual bodies. Here also. The central vessel surrounded by layers of tumor cells. Central vessel, layers of tumor cells. So the typical scalar dual bodies are absent in this given image of the question. So it is not a yolk sac tumor. Choriocarcinoma. Why not choriocarcinoma? Choriocarcinoma should typically show two types of cells, syncytial and the cytotrophoblast. Here, this is the image of choriocarcinoma showing you this is the syncytial trophoblast. Syncytium means it gives an appearance of multinucleate. So there are syncytium means it gives an appearance of multinucleate. So there are multiple nuclei here. They have abundant eosinophilic cytoplasm is present. This is the abundant eosinophilic cytoplasm, but there is no distinct cell border. Distinct cell borders are absent. Hence, it is called syncytium because it appears as if it is a multinucleate. Gives a multinucleate appearance because of lack of distinct cell borders. Distinct cell borders. This is said to be a syncytiotropoblast. And the cytotrophoblast here, this zone, contains this mononuclear cells, contains this mononuclear cells. This is a single nucleus, clear cytoplasm around it. This mononuclear cells is the cytotrophoblast. This presence of syncytio and cytotrophoblast is characteristic of a choriocarcinoma, which is not given in this image attached. Coming to the other option, teratoma. Teratoma means tumor which has two or more than two germ layers. Arises from two or more than two germ layer of cells. So it contains derivatives of both ectoderm, endoderm, mesoderm, where the two or more than two of these layers can be present. So it is like a mixture of all mature tissues. Here this is the hyaline cartilage. Here it shows a cartilage. Here these are the apocrine glands. Certain glands are seen. This is a mature epithelium. Here epithelium is seen. Here again adipocytes are seen. So it is a mature teratoma. This is a teratoma. Also it may contain like thyroid tissue, bone, cartilage, respiratory epithelium, and other bone, brain tissue, glial tissue, all at one place. So mixture of many such tissues is present characteristic of teratoma, which is not seen in the image attached here. Here it typically shows this fried egg appearance of cell septa containing lymphocytes, which is the characteristic feature of seminoma. Hence, all these options are excluded. Coming to the fifth question, a child presents with visual disturbances, delayed growth. Imaging reveals a supracellular mass. Histopathology shows presence of wet keratin. Histopathology shows presence of wet keratin, that is compact eosinophilic anucleate keratin. What is the most likely diagnosis? The given options are craniopharyngioma, medulloblastoma, glioma, pituitary adenoma. So what are the clues from the given question? It says a child, pediatric age group, and visual disturbances, delayed growth, and supracellular mass on imaging. Histopathology showing wet keratin. So there are five clues. child, visual disturbances, delayed growth, suprasellar mass, wet keratin on histopathology. Let's see each of these options. So firstly, the craniopharyngioma. It is a tumor that arises from the Rathke's pouch, the remnants of Rathke's pouch, which will later develop into anterior pituitary gland. It typically arises from this suprasellar region. Typically arises from the suprasellar region, which is close by to hypothalamus, optic chiasma, pituitary stalk. Hence, because it is in close proximity to this, it compresses. The tumor arising from suprasellar mass will compress on the optic chiasma. It will compress on this optic nerve, lead to visual disturbances, and also it will compress on this hypothalamus pituitary axis. It is close by to hypothalamus and pituitary. It will compress on it and will lead to deficiency of growth hormone, therefore the delayed growth seen in that child. And craniopharyngioma, most common age group is pediatric age group. So all the criteria are satisfying: suprasellar region, a child, and this delayed growth, visual disturbances. Also on histopathology, the craniopharyngioma shows this typical wet keratin. These are the keratin nodules which are anucleate. They are anucleate, clear eosinophilic. They are eosinophilic keratin material, squames called squamous cells. Squames, anucleate eosinophilic squames. This is called wet keratin, which is the exclusive. This is the exclusive diagnostic clue for craniopharyngioma. So all the criteria are meeting for craniopharyngioma. Let's see the other options also. Let's see medulloblastoma. Medulloblastoma is a tumor that arises from the cerebellum. They arise from the cerebellum. Location is cerebellum, not the suprasellar area. And also on histopathology, the medulloblastoma, they typically show Homer-right rosettes. Homer-right rosettes. These are the Homer-right rosettes. So even this option can be excluded. Coming to the glioma, which is the tumor arising from the glial cells of the brain tissue. The glial cells are the astrocytes, oligodendrocytes, ependymal cells. So they arise from glial cells, which are the non-epithelial cells. They are not the epithelial cells. That means there will be no keratin. Keratin is formed only by the epithelial cells. Since these are non-epithelial cells, they cannot produce keratin. So no keratin means no wet keratin, which is given in the question. So this option is also excluded, the glioma. Coming to the pituitary adenoma, last option. Pituitary adenoma, it arises from the sellar region. Location is sellar region. Also the age group, it is an adult tumor. It is an adult tumor. It is very rare in a child. So because of age exclusion also this option can be excluded. Sellar region, adult age group. Also, it's a tumor of anterior pituitary, so there will be excess of hormones, increase in hormones like the prolactin growth hormone. Because of increasing growth hormone, there will be gigantism. But in a given question, it is saying delayed growth. It is the opposite of pituitary adenoma. So even the pituitary adenoma can be excluded. So the only option we are left with is the craniopharyngioma. The exclusive diagnostic clue is wet keratin. Also the age group, child is fitting, visual disturbances, delayed growth, suprasellar mass. All this fit to the craniopharyngioma. Hence the answer is craniopharyngioma. Coming to the sixth question, a 16-year-old boy presents with jaundice and splenomegaly. His father had similar illness during adolescence. The MCHC was high. What is the most likely diagnosis? The options are iron deficiency anemia, hereditary spherocytosis, thalassemia major, autoimmune hemolytic anemia. So from the given questions, it is a 16-year-old boy. That means it started in adolescence. Also, the father had similar history during his adolescence. Father had history, father passed on the disease to his son. That means it shows an autosomal dominant inheritance. Father transmitting to the son, father to son, autosomal dominant inheritance. And MCHC is high. That means the hemoglobin concentration per RBC is high. So the most likely diagnosis from the given options, hereditary spherocytosis fits into it. Hereditary spherocytosis is an autosomal dominant disease. It is transmitted autosomal dominant inheritance. Also, hereditary spherocytosis means it is because of defective RBC membrane proteins. RBC membrane defect is there. Like spectrin, ankyrin, band 3, protein 4.2. Because of these membrane protein defects, RBC membrane defect occurs, because of which RBC, the cell surface area decreases. There is decrease in the surface area. That means the surface area to volume ratio also decreases. The volume remains the same, but the surface area decreases because of loss of membrane. Surface area decreases, because of which the RBCs, they change their shape from the normal biconcave to round shape. They become round. Hence, they are called spherocytes. Spherocytes are the rounded RBC. Spherocytes are round RBCs which have low surface area. So, because of low surface area, the dehydration occurs. Therefore, MCHC is high. MCHC is high. As the surface area decreases, RBCs become round. They undergo dehydration, because of which the hemoglobin concentration per RBC increases. Therefore, MCHC will be high. Also, because they become round, their deformability decreases. Deformability. That means ability to change its shape. Change the shape. That is flexibility of RBC while passing through narrow canals, narrow capillaries. So whenever these spherocytes, they pass through the spleen, they get trapped in the splenic sinusoids and the splenic cords. They get trapped in the spleen, in the capillaries, sinusoids and the cords. So the normal RBC is 7 microns in diameter, whereas the splenic capillaries, the narrow capillaries, they are 2 to 3 microns in size. Hence RBCs, these spherocytes, get trapped in this narrow capillaries. Because of trapping, there is splenomegaly. There is splenomegaly seen here. And also they undergo the splenic macrophages. They come and act on this trapped spherocytes. Macrophages will destroy the spherocytes. RBC is broken down. Hence, there is jaundice because of increase in unconjugated bilirubin. The unconjugated bilirubin increases, because of which there is jaundice. That means hemolysis is occurring. Where is the hemolysis occurring? RBCs are being broken down by the splenic macrophages in the splenic cord sinusoids. That means out of the blood vessels. Hence, it is an extravascular hemolysis occurring in hereditary spherocytosis. So, all the features fit in this autosomal dominant kind of inheritance, because father is passing it on to the son, and also the age group in adolescence. It is most commonly seen in adolescence. Because of this membrane defect, surface area decreases, therefore they become round. MCHC is high. High MCHC is fitting. Also the splenomegaly and the jaundice because of hemolysis, extravascular hemolysis, all these are fitting into this hereditary spherocytosis. Hence, the best answer here is hereditary spherocytosis. Let's see why not the other options like iron deficiency anemia. The iron deficiency anemia, it is like nutritional deficiency because of low iron, either in dietary form or inadequate absorption, whatsoever reason may be. The anemia is microcytic hypochromic. microcytic hypochromic. That means low hemoglobin. Hence, MCHC will be low. There's low MCHC which does not fit into this question. Also, there's no hemolysis occurring in iron deficiency anemia. That means no splenomegaly, no jaundice. And it does not show an inheritance pattern. It is because of nutritional deficiency. It is not passed on through generations. Hence, iron deficiency anemia is omitted. The other options are thalassemia major. Thalassemia major is an autosomal recessive disorder. It is autosomal recessive. That means in the given question, the history shall be either both parents shall be carrier. Both the parents will be carriers, not a single parent, strong single parent positive history will not be given in the question. Hence, this is also wrong. This autosomal inheritance pattern is wrong because both the parents will be carriers, not a single parent history. And also, it is thalassemia major. It begins in infancy stage, like it begins earlier. And it requires, because it is severe anemia, it requires blood transfusion. So it doesn't present in adolescence. Even the age is excluded. Also, the MCHC here will be either normal or decreased. So thalassemia major is also omitted. The other option is autoimmune hemolytic anemia. Autoimmune hemolytic anemia is an acquired disease. It is not inherited, hence omitted. And there is no family history, not inherited, no family history. MCHC will be normal. And the spirocytes can be seen on peripheral smear with direct test positive. And this autoimmune hemolytic anemia is associated with other autoimmune diseases and it is triggered by infections and drugs. No such history is given in the question. So the best option here is hereditary spherocytosis by omitting all other options. Coming to the 7th question, a patient presents with a mass in the front of the neck along with odynophagia and dyspnea, that is painful, difficulty in swallowing and breathlessness. Histopathology shows tumor cells positive for TTF1, synaptophysin, chromogranin. There is evidence of amyloid deposition. What is the most likely diagnosis? The options are papillary thyroid cancer, follicular thyroid cancer, medullary thyroid cancer, anaplastic thyroid cancer. So all the options are thyroid cancer. So swelling in front of the neck with breathlessness or the painful swallowing. That means even the options are, everything is given thyroid cancer. Now which type of thyroid cancer? Here they are saying positive for TTF1. TTF1 is positive. TTF1 is a marker for differentiated thyroid tissue. Differentiated thyroid tissue. And chromogranin synaptophysin. These both are the neuroendocrine markers. Neuroendocrine markers. And there is amyloid, one more strong history. So from the options, the best answer here is medullary thyroid cancer. Because medullary thyroid cancer, they arise from the parafollicular or the C cells, which are these neuroendocrine cells. These are the neuroendocrine cells. Hence, they show positivity for synaptophysin and chromogranin. Also, because of course, during this development, the C cells, they merge with the thyroid lineage. Hence, they retain this expression of TTF1. And amyloid deposition, that is the extracellular protein deposition, amyloid. It is like exclusive diagnostic clue of medullary thyroid cancer. Hence, the answer here is medullary thyroid cancer. Let's see why not the other options. Papillary thyroid cancer. Papillary also shows positivity for TTF1 positive, but they do not arise from the neuroendocrine cells. They arise from the follicular cells. Hence, the synaptophysin is negative, chromogranin is negative. And there is no amyloid seen in papillary thyroid cancer. Papillary thyroid cancer typically shows this orphan eye nucleus on histopathology. No amyloid in papillary. Similarly, follicular also they arise from follicular cells. Hence, these are also TTF1 positive. But since they are like arising from the follicular cells, not from the neuroendocrine cells, this synaptophysin chromogranin will be negative. Also in follicular cells, this tumor cells will be arranged in microfollicles, macrofollicles or varied size of follicle pattern and thick fibrous bands in between them. On histopathology, there is no amyloid in follicular cancer also. Let's see anaplastic. Anaplastic means it is highly aggressive and highly undifferentiated. It is highly undifferentiated. Because it is undifferentiated, the TTF1 will be negative here. Because it is undifferentiated, TTF1 is negative. TTF1 will be positive only when the tissue is arising from a differentiated thyroid tissue. When the cancer is arising from a differentiated thyroid tissue, it will show TTF1 positivity. Since anaplastic is highly undifferentiated, TTF1 will be negative. And also the chromogranin or synaptophysin neuroendocrine markers will also be negative. And there is no amyloid seen in anaplastic cancer. Hence, this is also ruled out. So the only perfect answer fitting this question with this TTF1 positivity, synaptophysin chromogranin positivity, neuroendocrine markers and amyloid, important amyloid. So the perfect answer fitting this question requirements are medullary thyroid cancer. Hence, we have concluded the answer of this question. Let's see the other question. Which of the following diseases exhibit the inheritance pattern shown? See, this is the pedigree chart. Here this is a female affected. The male is unaffected. The female has disease in the first generation. In the second generation, kids are affected. Is the female and male got affected. In the third generation, this female has transmitted the disease to her offspring. This female has transmitted the disease to all her offspring. Here, when male is affected, none of the offsprings are affected. That means what you can conclude, when a female is affected, she transmits the disease to her offspring, be it male or female. See here, female is affected. She is transmitting the disease to her offspring, whether it is a female or a male. Here is a female being affected, transmitting to the disease to her offsprings, female, males. When the male is affected, when the male has disease, he is not transmitting to his offsprings. That means it shows pure maternal inheritance. Pure maternal inheritance is the mitochondrial inheritance. Because mitochondria is given by mothers only. So it is mitochondrial inheritance. So from the options, let's see which one of the diseases show mitochondrial inheritance. First is the Kearns-Sayre syndrome, second Williams syndrome, thirdly achondroplasia, last cystic fibrosis. So the Kearns-Sayre syndrome is a disease which shows this mitochondrial inheritance. It has this mitochondrial inheritance. So this Kearns-Sayre syndrome, it has a typical onset before 20 years of age and it affects eyes, heart, CNS, muscles mainly. In the eyes, it shows progressive external ophthalmoplegia and pigmented retinopathy. In the heart, it shows conduction defects, the AV blocks or the bundle branch blocks. In the CNS, it shows cerebellar ataxia. Muscles show proximal muscle weakness. So this is about the Kearns-Sayre syndrome. Why not other? The Williams syndrome is an sporadic. So it occurs randomly because of microdeletion of 7q chromosome. So the pedigree chart does not show exclusive maternal transmission. Achondroplasia is autosomal dominant. That means even the fathers can pass on to the sons. Autosomal dominant means even when the male is affected, he can transmit the disease to his sons or the daughters. And it is often due to this new mutations of FGFR3 gene mutation. Cystic fibrosis is an autosomal recessive. There will be skipped generations. Either both parents will be carriers. This is about the 8th question. The mitochondrial inheritance shown by Kearns-Sayre syndrome. Coming to the 9th question. A middle-aged woman presents with dry eyes, dry mouth. Lab tests reveal positive anti-Ro, anti-La antibodies. What is the most likely underlying pathological mechanism? So dry eyes, see here, the question says it is a middle-aged woman who are more prone for autoimmune diseases. Dry eyes means keratoconjunctivitis sicca. Dry mouth means xerostomia, along with positive anti-Rho antilla. It points towards Sjogren syndrome, which is an autoimmune disease. What is the underlying pathological mechanism? Let's see the options. Destruction of exocrine glands by neutrophils, IgE-mediated hypersensitivity reaction, lymphocytic infiltration and destruction of salivary and lacrimal glands, deposition of amyloid in the salivary glands. So from these options, the pathological mechanism behind the Sjogren syndrome is the lymphocytic infiltration and destruction of salivary and lacrimal glands. Now the Sjogren syndrome, it is a chronic autoimmune condition which is mediated by CD4 T cells. It is mediated by CD4 T cells. That means T cells are lymphocytes. So all these lymphocytes, they infiltrate and destroy the lacrimal glands and the salivary glands. Because there is destruction of these glands, there is decreased salivary production and decreased production of tears, because of which the dry eyes, dry mouth occurs. Why not the other options? So destruction of exocrine glands by neutrophils. As we discussed, Sjogren syndrome is a chronic autoimmune. Chronic means it will show it is mediated by the T lymphocytes, not neutrophils. Neutrophils are involved in acute inflammation. So hence this is ruled out. IgE mediated hypersensitivity. IgE mediated means type 1 hypersensitivity. Type 1. Here Sjogren syndrome is mediated by CD4 T cells. That means CD4 T lymphocytes means type 4 cell mediated immunity. Hence it is not type 1 or the IgE mediated. This is also ruled out. Deposition of amyloid. No. Amyloid deposition makes the organ like a stiff, it does not produce the sicca symptoms or the dryness symptoms. Hence, this is also ruled out. The only correct option is lymphocytic infiltration of the salivary and the lacrimal glands, because of which these glands undergo destruction, low saliva production, low tear production, dry mouth, dry eyes. Hence, we have solved this question. Next, a patient presents with ovarian mass that is multiloculated and has a serum Ca 125 levels more than 1000 units per ml. What is the most likely diagnosis? Given options are serous cystadenoma, mature teratoma, granulosa cell tumor, serous cystadenocarcinoma. Firstly, it is saying there is a multiloculation. First clue. Serum Ca 125. Normal levels should be less than or equal to 35 units per ml. So it is highly elevated. That means malignancy. From the options, serous cystadenoma, it is a benign. It is a benign ovarian tumor. The Ca 125, it will be normal or it can be mildly elevated. It is a highly benign condition. So this doesn't fit it. Also, serous cystadenoma, most of the times it is uniloculated, or it can be few locules can be seen, not a multiloculated picture. Mature teratoma, it also doesn't give there are no tumor markers for it. There are no tumor markers. Also, it is a germ cell tumor which shows this multiple tissues like the tooth, cartilage, hair, etc. So even this doesn't fit. Even the Ca 125, it will be normal or it won't be elevated. Coming to the granulosa cell tumor, even this is a sex-cord stromal tumor. Here the tumor markers are inhibin A and B. These will be elevated. Ca 125 has no role in this granulosa cell tumor. Hence this is also excluded. Serous cystadenocarcinoma, it most likely fits because it is multiloculated. It shows multiloculations. And also, the serum Ca 125 will be highly elevated because it is a malignancy. Most common epithelial malignancy is Ca 125 highly elevated is serous cystadenocarcinoma. So the answer here is serous cystadenocarcinoma. So this image shows you a benign serous cyst adenoma only. Usually on cut section, it shows uniloculation, or very rarely multiloculations can be seen. It is filled with serous fluids. This is the malignant serous cyst adenocarcinoma. On cut section, it has multiloculations, and the surface shows this papillary projections on the surface. On the inner surface, it will have these papillary projections, and it is highly hemorrhagic too. This is the mature teratoma showing you this Rokitansky protuberance. These are the hair. Here you can see the tooth, the cartilage, etc. It has two or more than two germ cell layer arising from it. This is the granulosa cell tumor, which is highly hemorrhagic. It has like variegated appearance, highly hemorrhagic. Certain cystic places can also be seen. There is no role of this CA125. Only inhibin A and B will be raised in granulosa cell tumor. So this question we have solved. So multiloculation CA125 highly elevated. The malignant serous epithelial tumor here is serous cyst adenocarcinoma. Coming to the next question, a patient underwent ileal resection, subsequently developed anemia along with peripheral neuropathy. Features of subacute combined degeneration. Lab findings show hemoglobin 9 gram per deciliter. So there is anemia, mean corpuscular volume of 110 femtoliter. What is the most likely cause of his anemia? So from the question, there is a clue of ileal resection. Ileum resection. After which he developed anemia. What kind of anemia? It is a macrocytic anemia. Macrocytic anemia, because the normal MCV, that is the volume of each RBC, should be between 80 to 100 femtoliters. Anything above 100 will be macrocytic, anything below 80 will be microcytic. It is above 100 here, 110. Hence it is macrocytic kind of anemia. This hemoglobin is low, the MCV high. Macrocytic anemia following ileal resection, along with CNS symptoms like peripheral neuropathy, subacute combined degeneration. All this point towards what? Which option? Let's see. Iron deficiency anemia, vitamin B12 deficiency, folic acid deficiency, sideroblastic anemia. So the best answer here would be vitamin B12 deficiency. So vitamin B12, it is the best absorption site is the ileum. Here, ileum is the best absorption site. And vitamin B12 deficiency produces macrocytic anemia along with CNS symptoms like the peripheral neuropathy and subacute combined degeneration. Subacute combined degeneration. Hence, vitamin B12 is the most appropriate answer here. Why not the other options? Iron deficiency anemia is because of nutritional deficiencies, wherein this microcytic hypochromic anemia. That means MCV should be low, should be less than 80. So it doesn't fit this. And the absorption site for iron is duodenum and proximal jejunum. So this option will be omitted. Folic acid is also absorbed from the proximal jejunum. It produces like macrocytic anemia. Macrocytic anemia is there, but there are no CNS symptoms. No CNS symptoms. So this absence of CNS symptoms will rule out folic acid deficiency. So because in the given question there is like CNS symptoms, peripheral neuropathy and the SACD, because of which we are ruling out this folic acid, because folic acid deficiency will not produce any CNS symptoms. Sideroblastic anemia, it is because of this heme globin synthesis. Heme synthesis defect. Heme defect. Because of which there is excess iron like loaded in the sideroblasts. Because of excess iron. So it doesn't produce this macrocytic picture. There is no macrocytosis here. There is no macrocytosis, no CNS symptoms seen in sideroblastic anemia. Hence this option is also ruled out. The only prompt option here is vitamin B12, where the absorption site is this ileum and produces macrocytic anemia with CNS symptoms. The next question is, CD markers can be detected by which of the following tests? Cytogenetics, next generation sequencing, flow cytometry, karyotyping. So straight away answer, CD markers are cluster of differentiation. CD markers means cluster of differentiation. These are the cell surface proteins, that is the antigens. That means they are the antigens, cell surface antigens, that means the proteins expressed on the hematopoietic cells. They are expressed on hematopoietic cells. So the cell surface proteins will be detected by flow cytometry, straight away answer. So the flow cytometry is a technique by which when you take a sample, the sample can be a blood, peripheral blood or bone marrow aspirate or an FNAC from a lymphoma sample, any of which can be a sample. When you suspend this cell suspension in this nozzle through, you add the sheath fluid and you apply a hydrodynamic pressure. When you apply a hydrodynamic pressure, the cells here, they are allowed to pass through this nozzle one by one in a single file. They pass in a single file. And each of these cells, like which are the cells? If the cell is carrying CD3 marker, they will be attached to this anti-CD3 marker, anti-CD3 antibody, which will be given a green color. If there is a CD19, it will be given a blue color. If there is CD23, it will be given some other color like yellow, let's say yellow. When you add this antibody to them, so these cells, whichever the antigen they carry, they are tied to this dye, specific dyes. When they pass through this laser light, a laser light is allowed to hit this cells. Each of these cells, because of this laser light hitting them, they get excited and emit light. Either it can be a forward scatter light. Forward scatter means there's increase in size of the cell, or it can be a side scatter. Side scatter because of complexity of the cell complexity. That means more granularity of the cell. More the granularity, more the side scatter. More the size, it will be a forward scatter. So depending on that, the cells get scattered. When they are scattered, depending on their antigen, for example, a CD3 cell is there. When it is scattered, it is recognized by that green signal, by that same detectors, fluorescent detectors. When it emits green, it will be detected as CD3. When it emits this yellow light, it will be detected by this fluorescence detector, and yellow is assigned as CD23. If it emits blue, it will be detected as CD19. This is how cell sorting occurs, because depending on that emitted light, which will be like caught by this fluorescence detector, cell sorting occurs. All the CD19 here, all the CD23 here, all the CD3 here, cell sorting occurs depending on the CD markers. This is called the flow cytometry. Why not the other options? Cytogenetics is like a chromosomal study. It will detect chromosomal abnormalities like the translocations, deletions or duplications of the chromosomes. This next generation sequencing will detect the gene mutations, the gene sequences on a DNA, how the nucleotide sequences occur, the base sequences it will detect. So it will detect gene mutations, insertions or deletions, and the fusion of the genes. Karyotyping is also a type of this cytogenetics where gross chromosomal structure can be studied. So all other options can be ruled out. All other options are ruled out. The best answer to identify the CD marker is flow cytometry. Coming to the last question, a cut section of liver shown below, what is the likely diagnosis? So here this is the given image. This is the entire thing is lesion with a central scar here. So this is the lesion. This is the lesion. Central, there is a central fibrous scar. This is a central classical central stellate fibrous scar. So stellate means like star shaped. It is like highly radiating. So central stellate fibrous scar is seen with fibrous septa radiating. So the diagnosis, like the gross diagnostic clue of the central stellate fibrous scar is seen in focal nodular hypoplasia, FNH. Straight away answer is FNH. So why not the other options? Let's see the other options also. Hepatic adenoma, it is soft yellow in color, it is benign, soft, it has yellow tan areas, it is fleshy here. Yellow tan areas, hepatic adenoma, it is well circumscribed also. So this is not hepatic adenoma. The given image is not like this. This is the HCC, hepatocellular carcinoma, HCC. So it has this ill-defined margins or infiltrator, as if a tumor is infiltrating the surrounding tissues. It has a variegated appearance. See, hemorrhagic areas are seen, necrotic areas are seen, certain fleshy areas are seen. So this HCC has ill-defined margins with various areas of hemorrhage, necrosis, fleshy areas also. This is HCC. Other option is hemangioma. Hemangioma shows this typical honeycomb appearance. Here there are certain zones of hemorrhagic areas like blood-filled spaces. These are the blood-filled spaces, almost like a spongy. It has a spongy honeycomb appearance, which is like red-brown in color. With you can clearly see this blood-filled spaces here. These are the blood-filled spaces. Blood-filled spaces mixed with, like interspersed with certain fibrotic areas also. So this is an hemangioma. The given image here clearly shows the central stellate fibrous scar. This is the lesion. This is the entire lesion. In the center of the lesion is the central stellate fibrous scar. Fibrous scar. Fibrous scar will be like fibrous tissue will be extremely white in color. This is the fibrous scar in the center of lesion. Classical diagnostic gross clue of focal nodular hypoplasia. So these are all the questions related to the NEET PG 2025. So if you found this video useful, please like, share and subscribe to our channel. Thank you.